A very big hello to all my dear students. So today we are going to start with sclera. You all know, you must be aware, sclera is a very small and crisp chapter. We are going to discuss all the important things that are needed to know for your exams, okay? And whatever the questions have been asked. So let's start. So when you say sclera, we all know it is the white part of the eye that you see. It is one of the toughest structure. Sclera, you know, it is again a Greek word, sclera, which means hard, right? So the 5th, 6th outer coat we all know is your scleral and 1/6 is your cornea. Cornea is transparent, sclera is opaque, we all know that, and it is white in color. Now why it is opaque, we can note down that it is scattering all wavelengths of light. So it is scattering all wavelengths of light. Right? So therefore the sclera is opaque. Now once we are talking about that, this is what is the role of sclera is mainly your giving the shape to the eye and protecting the eye. So there is an exam question, I am mentioning it here only, that which is the most radio resistant structure in eye. Okay, so most radio resistant, you should answer sclera, common sense. Most radio resistant structure of the eye, we will answer sclera. Hope you are writing, I am writing in this only. Secondly, they can ask you, let us solve this question also, that which is the most radio sensitive structure of your eye. So if they ask you about the radio sensitive, now our answer will be lens. Okay. So most radio sensitive, it is lens. Next we are going to understand, the second question they have asked you is about the thickness of sclera. Where is the sclera thinnest? This was your question. So we are going to learn 3 important places where we have to know the thickness. One is around the lamina cribosa, the thickness is 1 millimeter. All of you can make this diagram yourself, and just note it down that at the lamina cribosa, here around here, this becomes 1 millimeter. Then at the corneoscleral junction, it is 0.83 millimeter, and wherever that is the muscle is inserted, right? So at the muscle insertion, it is around 0.3, anteriorly it is 0.6 and posteriorly it is 0.3. So this is important. So anteriorly it will be 0.6 mm, but posteriorly it is 0.3 mm. So where is the sclera thinnest? Where is the sclera thinnest? At the insertion of the muscle, especially the recti muscle, anteriorly or posteriorly. So now you know very well it is posteriorly. Okay. So thinnest at the muscle insertion, note down, at muscle insertion, right, you will say posteriorly. Okay, come to the next question. If I ask you which is the most common site of globe rupture, again common sense, it has to be at the muscle insertion. So most common site of globe rupture at the muscle insertion, right. We can also write it as most common site of scleral rupture or globe rupture. Scleral rupture or globe rupture, we will answer posterior to the muscle insertion. So these are the questions they have asked you. Next we talk about is what are the different layers of the sclera. Let us make it in our way, a simplified way. So the superficial most part of the sclera is what we call episclera. So we have learned sclera, then episclera, then tenon's capsule and conjunctiva. So uppermost is your episclera, right? Then comes your substantia propria or scleral part. We can call it sclera proper. And then comes a little looser connective tissue which we call as lamina fusca. I am just putting it in a most simplest way, okay. Below this is going to be, then it is not below exactly, if innermost to that will be, inner to that is your choroid, isn't it. So choroid, the space between the sclera and the choroid, this is your suprachoroidal space. So this is the suprachoroidal space if we take this as a choroid, right. So now I think you have understood these are the different layers. So, three main parts. Okay, once we know about this episclera, then we talked about this denser part. This is your sclera proper, and then a little more loose connective tissue is lamina fusca. Can we also know one line about each, please? Episclera is a thin vascularized connective tissue. Okay, so we will learn it here as what constitutes episclera is nothing but, write down, it's a vascularized connective tissue. 1 or 2 points here. And what does it has is collagen fibers and fibroblasts. Okay, so collagen and fibroblasts. This is enough. Of course, there will be blood vessels and nerves. Okay, so this is about episclera. Then we talk about is sclera proper. Now, sclera proper, what do you have to know in this? It is relatively avascular part of the sclera. Okay, so it is relatively, not like totally avascular, but relatively avascular. It will get its blood supply from some channels through the choroid or from the episclera. So, all the nutrition and blood supply is from either episclera or the choroid. Okay, and what does this sclera proper? It is a dense tissue, right? So, it has collagen fibers, anelastic fibers, fibroblasts, and the ground substance, it is mainly glycoproteins and proteoglycans. So, this is your right. So, this is your sclera proper. What did we learn? It is getting all its vascular supply either from the episcleral vascular bed or from the choroid. If you want to note down, you can note. Then comes the innermost layer. Innermost was lamina fusca. We will learn lamina fusca 2 points. First, it is a loose connective tissue. पहली चीज लिखिए, this is a loosely arranged connective tissue, right? And it has melanocytes. So, one point we are learning here, it has melanocytes. These melanocytes are actually migrated from choroid. These are migrated from choroid. So, a few extra points for the sake of learning, right? Okay. Once we know all this, this is the structure of the sclera. I will just show you the slide. We come to what are the different scleral apertures that you have to know. Write it with me. This is your eye. I am writing again. So, we are learning scleral apertures. Posteriorly, what are in middle and anteriorly. So, posteriorly we have to learn about this one, exit of the optic nerve, that is one aperture at lamina cribosa, right. What is this next? We were talking about was long and short posterior ciliary arteries and nerves, arteries as well as the nerves. Then in the middle, what are the apertures? Here we are going to learn about vortex veins. So, vortex veins, they are forming the apertures in the mid part of the sclera. They are just 4 millimeter behind to the equator. What is equator? From anterior posterior, if this is the diameter, the middle is the equator in the eyeball. So, these are the vortex veins, their exit of, sometimes mainly there are 4 vortex, sometimes it can be 5 vortex veins, and vortex veins drains what? Uveal tissue, that is iris, ciliary body and choroid. If you want, you can make all 4. Then we talk about anterior. Anterior will be anterior ciliary artery and anterior ciliary nerves. Okay? So, we will just learn like this, anterior ciliary artery and nerves. Let us have a look at the slide. So, these are the 3 layers here. The below one, this is lamina fusca. You can see the melanocytes. This is the stroma and episclera. It should be stroma, right. So, these are the layers of the sclera. Okay. Then I will come to this little later. First, talking about the apertures. As you can see here, long posterior ciliary artery, short posterior ciliary artery and long ciliary nerves. Nerves and arteries, these are all, of course, arteries and veins, both the vessels are forming their purchase. And in the middle, it is the vortex veins. And what is anterior? Anterior ciliary artery and vein. Okay, so it is anterior ciliary artery, and everyone should know this. I'm reminding you about the anatomy that anterior ciliary artery is near the insertion of all the recti. Every recti has two except lateral rectus, which has only one anterior ciliary artery. So these are all muscular branches. Anterior ciliary arteries are muscular branches. Okay, and coming to this slide, what we have to remind ourselves that at the limbal area, the three layers, that is conjunctiva, tenons, capsule and episclera, they fuse together at the limbus. Okay, yeah, and this one is your sclera. So that was the basic anatomy we should be aware of. We next talk about, after this is, let us have a look at this one. So when you are talking about episcleritis or scleritis, right? So let's give the heading first. Scleral inflammation. Scleral inflammation can be either episcleritis, okay, when the episclera is involved, or it could be scleritis. All of you keep this in mind that whenever there is a scleritis, definitely there will be episcleral inflammation also. But vice versa is not true. That means we can have an independent episcleritis as well. So keep this in mind. Anyway, so when we are talking about episcleritis and scleritis, definitely the major clinical difference, if I talk about, is presence of pain or no pain. So why is there pain in scleritis? It is due to the long and short ciliary nerves that are crossing the sclera. So keep in mind, pain is not a feature here. This is a benign self-limiting disease, episcleritis, with no pain. You know? But when it comes to scleritis, there is pain, tenderness. I'm just going to talk about all in detail. And this is all because of the long and short ciliary nerves. Now, why are we talking about all this? A patient presenting with a nodule and a congestion can be confused with three main conditions. Is it a flectanular conjunctivitis? Is it episcleritis? Or is it scleritis? Let's see. So here see, you are looking at this patient. Look at the clinical picture. It's a nodule which is congested. This one is nodular episcleritis. When we see the next one, okay, this is a flectanular conjunctivitis. Okay, and this one, this is just a scleritis, which is a nodular scleritis. How do we differentiate these three nodules? So that is done by, of course, clinically I told you that scleritis, we will have pain, which is not a feature in either flectanular or in episcleritis. But you all remember flectanular? We had learned in conjunctiva chapter, it's an allergic conjunctivitis, endogenous antigen, right? Okay. So apart from that, pain and tenderness being a feature, this cannot be definitive. How to differentiate? Let us talk about phenylephrine test. So this is the test which helps. So this is why we have a test, because it's so confusing, right? So phenylephrine test is what? So phenylephrine test is that you have a patient with this type of clinical picture, put 1% phenylephrine to this patient. If this phenylephrine, putting 1%, the blood vessels are blanching, then it is a conjunctival congestion. That means we are looking at flectanular keratoconjunctivitis. Okay? But suppose this has not blanched. Once this has not blanched, my next step will be, let me increase the concentration of phenylephrine. Now I give 10% phenylephrine instead of 1%. Now again I see, is it blanching or not blanching? If it blanches with 10%, if the blood vessels blanch, this is episcleritis. But if it is not, then this is scleritis. If not blanching, then this is scleritis. So this is an important test at your level. It has been asked in the exam. We can put a Q and understand it. Now what is the explanation? If you look at the explanation, here it is. So the episclera has two types of, one is deep episcleral plexus, one is superficial. So in case of episcleritis, it is the superficial episcleral plexus which is congested. In case of conjunctivitis, it is the conjunctival plexus that is congested. right? These are all branches of mainly anterior artery. So this is the reason, because scleritis, it is the deep plexus which is congested, this does not respond to even 10% phenylephrine. So this test helps me to differentiate between conjunctivitis and episcleritis and scleritis. Okay, so a few lines about episcleritis first. So episcleritis being the inflammation in the episclera. I think we have done this. In clinical feature, we have just talked, okay, few points, that it is actually a benign and recurrent disease. Benign but recurrent disease. So that is a problem. That's a recurrence is there, benign and recurrent. And this is mainly a disease of middle age. It's a middle age disease. More common in females than in males. This doesn't seem to be very important information as such, but you should still know this. It is more common in females, episcleritis, and this episcleritis is generally self-limiting. It will be treated by its own, self-limiting in majority of the cases. Right? How will this patient present? The patient is complaining of discomfort, something is pricking the eyes, that is your grittiness, right? So, discomfort, grittiness, but of course, pain is not a feature. And when I am looking at it, it will depend. Is it a diffuse type or nodular? If it is a nodular, then I get a nodule near the limbus, as you have just seen in the picture I have shown you. Otherwise, it could also be a diffuse type. How can I confirm? We will not forget the phenylephrine test which I just discussed with you. Right? In any circumstance, how are you going to manage it? So the management part we have to know is just go for cold compresses. Right? We can even go for refrigerated lubricants. Lubricating eye drops, put it in the fridge and then use it. Okay? So refrigerated lubricants. Oral NSAIDs is the mainstay. Topical will not work. If needed, mild or weak steroids, topical steroids. Weak, why you don't want to use strong? You all know it can cause cataract or glaucoma. So weak, topical steroids. Right? So this can be the approach of, and when you say oral, it is mainly ibuprofen or indomethacin. Most commonly, which is preferable is ibuprofen or indomethacin. Ibuprofen or indomethacin. Right. So this is how we want to manage a case of episcleritis. Okay. Now very, very important point here. We will put a Q, which is the association of, if I talk about associations in episcleritis, we will divide this into ocular and systemic. Okay. Ocular and systemic. And this was your exam question. It is a very important feature of Crohn's disease. Put a Q there, all of you. Also seen in ulcerative colitis. So we will not forget this, number one. Secondly, you can learn is it can be seen in herpes zoster and vascular disorders like rheumatoid arthritis. Okay, rheumatoid arthritis. These are some systemic associations. Patients of rheumatoid arthritis or a prior history of HZO, they are all prone for your episcleritis. And ocular association, two important ones I am telling you. One is dry eye and one is contact lens wear. We will keep this in mind. Dry eye and contact lens wear. Right? So that was about episcleritis. We next talk about is scleritis. Give the heading, scleritis. When you say scleritis, simple hai, it is inflammation of sclera. Right? So when you say inflammation of sclera, associated with infiltration and edema. Let's add it. It is with edema and infiltration and cellular infiltration. This is how we define your scleritis. And most commonly, why it is happening in any person? Most commonly, this is immune mediated. Most commonly it is immune mediated. Otherwise it's a rare thing. It's not common. If it is there, it is generally immune mediated. In connective tissue disorders, it is much more common. The patients of rheumatoid arthritis, it is very common. Polyarthritis nodosa, it is very common. Okay. So, coming to classification of scleritis. Let us divide scleritis as anterior and posterior scleritis. Anterior and posterior scleritis. Now, anterior is, so in our latest classification, we are only dividing anterior, not the posterior one. Okay, this is the recent one, so there are some changes there. Okay, so anterior scleritis, and what do you mean by anterior and what do you mean by posterior? Anterior to the equator is anterior, behind the equator is posterior. So anterior scleritis, which is anterior to the equator, if you want to write it, and behind is here, behind the equator is posterior. This is further divided as non-necrotizing and necrotizing. Non-necrotizing and necrotizing. Now, non-necrotizing can either be nodular or diffuse, just like episcleritis we have learnt. Necrotizing can be with inflammation or without inflammation. With inflammation or without inflammation. When we say with inflammation, this can either be vaso-occlusive. Most important example is seen in rheumatoid arthritis. It could be granulomatous. Next type is granulomatous. These are the three types they have divided. Or it could be surgically induced. Granulomatous examples can be polyarthritis nodosa, polyangiitis. Okay. And third is surgically. What about without inflammation? Without inflammation, we should know, this is important and for our exams, scleromalacia perforans. Scleromalacia perforans. Let me write here. So, without inflammation is scleromalacia perforans. Right? This is the basic information you should have. A few points in each. Okay, let's have a look at the different clinical slides, how it looks. We just saw nodular scleritis. This becomes a diffuse scleritis with no nodule. Again, how will I differentiate it's a scleritis? Presence of pain, tenderness, and not responding to 10% phenylephrine. Simple. Easy? Okay. This is necrotizing but with inflammation. This is a case of necrotizing with inflammation. So you can even see congestion around it. Again, this is a diffuse scleritis. This is necrotizing without inflammation. Can you see? Almost the eye is white. There's a lot of thinning of the sclera and that has led to ectasia, which is called staphyloma. So actually this is a case of scleromalacia perforans. So name is perforans because it looks like it will perforate, but it does not perforate until the intraocular pressures are more. Keep this in mind. Okay, few points about, first we take anterior scleritis. Anterior scleritis, that is, it can be, we will talk about first non-necrotizing. Now, again, we are very clear that this patient will complain of pain. Yeah, before I go to the clinical features, one more thing. Just remember, here also, it is more common in females. Okay, and it is a disease which starts from 5th decade. Presentation is around 5th decade onwards. Right? Okay, so when you talk about scleritis and anterior scleritis, first non-necrotizing variety, patient will have pain. We have just talked about tenderness. We are just repeating what we discussed. And of course, discomfort and grittiness. Right? It can also affect your vision. Keep in mind. And of course, when you talk about the phenylephrine test, what we will answer? Will not blanch. So phenylephrine test will show that it is not blanching. What is the on-examination finding? You have seen the slide already. Either it is nodular or diffuse. This is again simple, nodular or diffuse. With congestion, this will be the finding. Right? Okay. So how are you going to manage? So let us talk about the treatment part. When you talk about the treatment, again it will be the same that we've mentioned earlier. We started with refrigerated lubricants, cold compresses, refrigerated lubricants can be given, or simple lubricants, but this one will cause more comfort. That is why we are mentioning like this. And of course, then what we may need is topical steroids to control inflammation. We start with the weaker steroids first, and systemic or oral NSAIDs. Generally, non-necrotizing variety we are able to manage like this, just as in episcleritis. We can add here that we may need also systemic steroids. Systemic steroids. Now talking about necrotizing. Necrotizing antiescleritis. Let us learn. The necrotizing antiescleritis, we said with inflammation. I've already given you the examples and causes, or it could be without. So it is more aggressive condition, right? Associated with autoimmune diseases, right? Keep this in mind. Presentation, again, if it is talking about with inflammation, you will be getting it is again a aggressive form of scleritis. What is needed that in detail for us at our level is to talk about without inflammation, that is scleromalacia perforans. So one was with inflammation and one is without, right? So let us talk about now. I'm not repeating with inflammation, the causes we have written in the classification. Just remember, it's again an aggressive form of scleritis. It's an aggressive disease, and this aggressive form of scleritis will need your systemic. So here comes the role of systemic immunotherapy. We'll talk about the details of immunotherapy at the end. Let me first finish the types of scleritis. We then talk about without inflammation, that is scleromalacia perforans. First important, give the heading here separately. First important question they have asked you here is about that this is a disease of long-standing rheumatoid arthritis. Okay, so all of you note down, make a cue here. Everybody make a cue there. It's a disease of long-standing rheumatoid arthritis. Correct? Okay. So this is important, and how will it start? As you have seen in the slide also, like a necrotic patch, and this necrotic patch is slowly causing scleral thinning, and this scleral thinning is finally leading to exposed uveal tissue, right? And we should note it down, though the name is perforans, perforation does not happen. It only if IOP is raised. If IOP is raised, then it may perforate. Otherwise, not. Okay. This is your scleromalacia perforans. Again, if you realize here, in late cases, there is treatment, no effective treatment. We can't do much. Early cases, again, we are treating in the same line as we are treating an antiescleritis with either topical and systemic steroids. Topical in early cases, I may again start with the same as we have earlier mentioned, right? So it could be topical or systemic steroids. And one more thing we can write down, we can use topical or systemic anticollagenase. Again, it's a necrotizing type, so we may also need, generally we use a topical cyclosporine, but all this can be only done in early case. Later on, there is no effective treatment, right? And of course, we have to protect the eye from trauma. That is very important, protection from trauma. This is your scleromalacia perforans. That was antioscleritis and the different types of antioscleritis. Coming to posterior scleritis. Now, posterior scleritis becomes a more serious thing. First of all, it's very, very difficult to diagnose. It is generally missed. And any inflammation there, increased capillary permeability, leakage, edema, imagine. So what is happening? It is affecting the posterior segment. So this is actually threatening the vision. Okay. So it's a potentially blinding disease. First of all, remember this. It's a blinding condition. And it is generally diagnosed late or not at all sometimes, right? And maybe only when the complications are occurring, I mean to say this, then only we come to know it. So it is diagnosed late unless and until it is associated with antioscleritis. If antioscleritis is also present, we may be able to catch hold of it on time, right? Anyways, another important thing, this is a younger age. Presentation is in the younger age. So age of onset is less than. So we have been learning in 50s we get these antioscleritis and all. But here we are saying that here it is less than 40 years. Okay. And how does the patient of posterior scleritis present? Posterior scleritis patients, because of the effect, can present with different conditions, like there can be choroidal folds. Let's learn a few. Then there could be leakage between the sclera and the choroid. That is called uveal effusion, leading to choroidal detachment. So uveal effusion with choroidal detachment. What else? Retinal, exudative retinal detachment. Exudative retinal detachment. Then of course disc edema, right? That is edema around the disc. Then if the orbit part is involved, due to the scleritis, you may even get inflammation of the muscles and myositis. There is a lot of pain if there is myositis. And sometimes even mild proptosis. So these are the manifestations or presentation of posterior scleritis. We are talking about posterior scleritis. Correct? And how do you diagnose? Here comes your exam question. That's why we are learning this. Investigation of choice here would be ultrasound B scan. So what you see in the ultrasound B scan is a typical T sign. Inverted T or T sign, you see. What is T sign? So the limb of the vertical limb is the optic nerve, and the T is your fluid which is accumulated between the Tennant's capsule and the sclera. Right? So this fluid is filling the space as T sign. Let's have a look. Okay, so if you look here, this is your posterior scleritis. And because of that, there is bilateral disc edema. Okay, so posterior part is inflamed. And look at the ultrasound B's. You can see this part of the T is your vertical limb, and the horizontal is this can you see the equiescent area, all this? This is what is and there is thickening of the sclera, right? So all this is what is T sign. Sign of posterior scleritis. And of course, if there is retinal detachment, if there is disc edema, this all will be able to catch hold of in your ultrasound B scan. So this T sign has been once your exam question. Keep in mind. How will you manage? Coming to the treatment part, we already have discussed this so many times. If it's such a serious condition, we have to, apart from steroids, topical or systemic, we may need immunomodulators. Right? So immunomodulators, what are the groups and how we are using it? Let's talk about that. So systemic, topical and systemic steroids, right? Or we have to go for immunosuppressants and immunomodulators. Now what is important and recently seen that you have to keep in mind, that one group of drug, that is rituximab, or to be making it more easy, rituximab. So whatever suits you. This is particularly seen to be, this is the latest information in your 9th edition of Kansky, just note the name. So this is particularly effective for the scleritis. Okay, this is particularly effective to treat any scleritis, whether I am talking about necrotizing anterior or I am talking about posterior scleritis. Okay, so apart from that, what are the other immunomodulators that we can use? Either we can go for cyclosporine and tacrolimus, right? This group of drug that is called immunophilins, right? Or we may need, what do you call it, cytostatic drugs like cyclophosphamide, azathioprine, right? And on biologicals, we will not forget rituximab. Okay, so these are the immunomodulators we can use. The basis of treatment is generally the same that we have discussed. Okay, that was about scleritis. What next we have to know? Okay, before I move further, one more thing. So what are the, you can say, systemic associations of scleritis? Can we just think of what are the systemic associations of scleritis we have to learn? So one is your rheumatoid arthritis, very, very important. Then we have already talked about granulomatosis with angiitis, granulomatosis with polyangiitis. We have talked about polyarthritis nodosa, and of course relapsing, right one, relapsing polychondritis. I don't want you to keep mugging the list, just know the list, just read it, this is enough. Okay, so okay, and can we forget about Crohn's disease? No. So Crohn's disease is also in the list where you may get your, particularly we are getting an ulcerative colitis. What we are getting is episcleritis actually. That is more common than scleritis, but it can be there. Let's only write Crohn's for scleritis, not episcleritis. Okay, so Crohn's disease. So these are some of the associations of scleritis. Rheumatoid arthritis, and we are talking about some autoimmune disorders, and we are talking about Crohn's disease. These are most important ones that we have to know. Correct? Okay. We next talk about, so that was about scleritis. Coming to the next important topic is blue sclera. What is this? We just need to know what is blue sclera, what are the causes. So blue sclera is not that sclera is blue in color, we all know that. Very thin sclera, so that the underlying uveal tissue is visible. That is what is called blue sclera. Okay, so what can be the causes of such a thin sclera that underlying uveal tissue is visible? Whenever there is collagen disorder, formation of collagen is defective, maybe genetically. So one is your osteogenesis imperfecta. So we'll just list the causes here. Osteogenesis imperfecta. Second we will note down is Ehlers-Danlos syndrome. And of course, when you talk about the one that you have just learned, scleromalacia perforans, that can also be considered one of the causes, isn't it? Then of course, any cause of thin sclera could be even Marfan's where there is excessive stretching. Even that has been listed as cause of blue sclera, right? And there's one more syndrome which very long back they had asked you in your options. They don't ask, but you just know this, Hallermann-Streiff. So Hallermann-Streiff, what they had asked you, we will learn one more thing apart from blue sclera is the spontaneous reabsorption of lens. Unique thing, right? Just know this one line, that's it. This is your Hallermann-Streiff syndrome. Okay. So that was about causes of blue sclera. What else they are going to ask you in sclera? Just have a look at the slides. So have a look. This is your osteogenesis imperfecta, where you can see the thin sclera and the underlying uveal tissue. This is your Ehlers-Danlos syndrome, the hyperextensible joints, as you can see here. This is Ehlers-Danlos. So you can never forget this, huh? Okay. Then we talk about is staphyloma. Everybody knows what is a staphyloma? So what is a staphyloma? It's an ectasia of the eyeball, hai na? Along with that, there is herniation of uveal tissue. It's not only ectasia, there is herniation of uveal tissue, that is called staphyloma. Write it down. So what is staphyloma? We will define staphyloma as ectatic condition of eyeball with herniation of uveal tissue. Okay, so classification. According to whatever location from where the herniation or the ectasia is happening, we will divide staphyloma. Let's have a look. So look here, it could be anterior when it is coming from there is ectasia from the cornea. It could be intercalary, that is from the limbus. Then ciliary body, equatorial from the equator, and posterior. Right? Let's draw it for ourselves. So let us draw this in a simple way, something like this. This is enough. So all of you, any ectasia from anterior is your anterior staphyloma, right? Then through the limbus, this is your intercalary staphyloma, intercalary. Then ciliary body area, this is ciliary staphyloma. Then equatorial staphyloma. And finally, posterior staphyloma. Can we draw this like this? So first important question they've asked you is, which is the most common type of staphyloma? Most common type of staphyloma we will be answering is posterior. Okay. So make a cue here. So posterior, what is the main cause of posterior? How can the eyeball just go posteriorly ectatic? In myopia. When the axial length is increasing to such an extent that at the last it becomes ectatic. So the cause of posterior is pathological myopia. We will answer pathological myopia. Cause of equatorial? Scleritis. What is cause of ciliary? Again, most common is scleritis. You just saw a case of scleromalacia perforans, right? There was a ectasia. So that's also a type of necrotizing scleritis. What can be the other causes in ciliary? If we want to learn more, we can talk about trauma could be another cause, or absolute glaucoma. We all know absolute glaucoma, painful blind eye. So these can be three causes. I'm repeating. For ciliary, we can learn scleritis, trauma, or absolute glaucoma. For equatorial, let's just learn scleritis. Or I'm just picking the most important commonest ones. Intercalary, think yourself, that is through the limbus. So क्या होगा? Peripheral corneal ulcer, है ना? So peripheral corneal ulcer. What about anterior then? Here also there should be some weakening of the cornea and ectasia. So here also there is ulcer which has led to pseudocornea. You all remember what is pseudocornea? When this is not an actual corneal tissue, it is actually formed by inflammatory exudates. That is called pseudocornea. So the cause of anterior staphyloma, most common cause, or you can say majority of the times it is after pseudocornea, right? So these are the causes, and this is how we are going to learn the types of staphyloma and their causes, making it absolutely simple for you. Okay, so one or two more points that I need to add, just came across my mind, is when we were talking about investigation of posterior scleritis, let us also add that another mode apart from ultrasound B scan could be MRI and CT scan. We shouldn't forget that. Okay. So if you want, you can note it down here. So investigation one is ultrasound B scan, we have mentioned. And you can also say the second investigation where you get this T sign, right? And the second could be your CT or MRI. Okay. So that was all about scleritis. Okay, let's have a look at the different types of your staphylomas. So we just talked about the different types of staphylomas on our diagram. Now let us see the clinical cases. So this is an ectasia from the cornea. This is what is your anterior staphyloma, right? So this will be your anterior staphyloma. Then this one is intercalary. This is intercalary. As you can see, it is more near the limbus. This is ciliary, and this is a typical case of scleromalacia perforans and was also a slide as an exam question. Okay, so this is what is leading to ciliary staphyloma. So please note it down. This is a Q. So this is a slide of scleromalacia. So many of you get confused, ma'am. Is it scleromalacia perforans or is it ciliary? This scleromalacia perforans, this scleritis is leading to ciliary staphyloma. Clear? Yeah. So I know what you are asking. You would next ask me if both are given, what should I answer? Huh? Throw the coin. Because both are correct, both mean the same thing almost. Huh? So this is your scleromalacia perforans, which is leading to ciliary staphyloma. This is showing you, of course, we all can guess that is posterior staphyloma, where the axial length is, where the eye is ectatic posteriorly and axial length has increased. So this is best seen in your B scan. You can see it best here. Normally your B scan should be something like this, na? This should have been the bone. But if you see in this patient, what do you see? This is how it looks like. This is the posterior staphyloma. Ectasia posteriorly. Right? Very, very clearly seen on B scan, posterior staphyloma. Right, all of you? So, few questions, but still whatever questions, we should be able to answer all of them. And I tried to make it as crisp as possible for you. Okay, so thank you so much. Study hard, stay blessed and keep smiling. Thank you.